It gives me great pleasure to host this session, which is going to focus on training in endoscopy. It's very dear to mine and, in fact, Roland's heart, and we understand that it forms the pillar of success and later in life. And if you're going to have excellence, you need training every step of the way.
So what are the common problems? Well, there's often limited access to training, certainly protected training time. There's lack of time to be trained properly. Trainees feel rushed. Trainer takes over the scope too soon. Patients unsuitable for training and turn up on the list, certainly in our unit. And we occasionally have cancellations. So if you reduce the number of patients on the list to accommodate training, and then you lose patients because they're not suitable or they don't turn up, that really compromises what you can do. So I'd just like to finally talk about what we've been doing with polypectomy training to improve what we do. And we're very conscious that trainees come to competency without really being good polypectomists. And what we've introduced recently is specific polypectomy training days to give them exposure. And what I've done is we've created a vetting process for patients referred for polypectomy. So this is all within our endoscopy management system. And John, myself, and two colleagues, we vet all the referrals. We decide whether they're suitable for training or not. And if they are, then we make a note of their SMSA status. And then when we come to book the list, we know which patients we might use for different lists. Now, these sort of patients are regularly ending up on John's list for advanced therapy. We're mostly offering this level of polypectomy complexity in our training days. Now, it's early days. We've done a couple of these, got another one in a few weeks, but I would like to make this a permanent feature in our training program.
I want to introduce a concept now of opportunistic training, because I think this is where it's at, right? So all the stuff I've just talked about is very sound educational theory. Yes, you should have smart objectives, you should write them down, and you should track them to make sure you're acquiring them. But opportunistic training is really what we do on a day-to-day basis. And what happens is something happens during the procedure, and then there's a little bit of training, and then you do a little bit more of the procedure, then something else happens, and then you do a little bit more training, then you finish. And then what happens is the trainer will often say, okay, let's review your learning objectives. And you spend a lot of time talking about the learning objectives, which may or may not be relevant to what actually happened in the procedure. When the trainee really wants to set the objectives about what happened in the procedure, they want to talk about what happened in the procedure, not the construct of a learning objective, which may or may not be relevant. So please listen to the trainee, think about what has occurred during the training, and focus your training on the opportunistic things that occur during that procedure. So I want you to think of this in a different way. It's not something new. It's just putting the focus in a different place. Think about the learning objectives which are brought into an educational contract as a medium-term thing, and that most of the training is going to be opportunistic. And this may or may not relate to the learning objective. If it does, it's great because everything fits together. But if it doesn't, do not try to force the reflection on a learning objective if it's not relevant to the what we call the key take-home messages for that particular session. And to do that, you've got to have that understanding, and you really got to have internally got to have that barometer and be adaptive to the training. So you've got to understand of what's going on dynamically in the procedure itself, what the trainer really needs, and marry that to the long-term goals. And if you're very skillful at this, this dialogue that you have with the trainee will be much more effective moving forward.
And he told me that he's had a little bit of, not trouble, but it's been difficult adjusting to that. But just watching him and his scope handling for a couple of minutes, I don't think he's got a huge problem. We've had a discussion about the umbilicus in front of his elbow, and Tamas, being a tall guy, has very long fingers, and I can see that he can control the wheels with both the fingers and the thumb, and I'm less concerned about the position of the umbilicus I would be. So there's a couple of things we talked about. One was his resolution of loops, prevention of loops, interpretation of the scope guide. He said he had a particular problem with a high riding splenic flexion and a deep transverse colon, and secondly with deep intubation of the cecum sometimes. So those are the sort of things he would like to focus on. Now we've got this far and we're in the sigmoid at the moment, you can see that. And we had a discussion about where the tip was, and Thomas rightly understands that the tip has come anterior and slightly to the left, and there's some angulation on it. And he was about to go forward, and I think this is going to be potentially a little bit tricky, so I stopped him